I want you to just imagine a pain that is so sudden, so overwhelming, that patients almost universally use these three words to describe it: severe, sharp, or tearing. This isn't just pain, it's a signal, a visceral alarm bell that something fundamental, something catastrophic, has just gone wrong inside the chest. So, what in the world feels like this? It's a condition where the aorta, the massive superhighway for blood pumping out of your heart, literally begins to peel apart from the inside out. This is the calling card of an aortic dissection. Okay, so let's focus on that incredible pain for a second. It's not just a symptom, it's a clue. In fact, where that pain is located gives the medical team their very first hint about what's happening and where. And this is where it gets really interesting. If the patient feels that tearing pain in the front of their chest, doctors immediately start thinking type A dissection. That involves the first part of the aorta, the section coming right off the heart. But if that pain is in the back, right between the shoulder blades, that points to a type B dissection, happening further down the line. This might seem like a small detail, but believe me, that distinction changes everything. We'll see why in just a minute. So we know the pain is a huge clue, but what is actually happening inside the aorta to cause it? Let's get a really clear picture of what an aortic dissection is. Okay, think of your aorta like a super high-pressure garden hose, but one that's built with three distinct layers. In a dissection, a tiny tear happens in that innermost layer. And because the blood pressure is so immense, blood just forces its way into that tear, creating a brand new false channel between the inner and middle layers. It literally peels them apart. That is the dissection. And it turns out not all damage to the aorta is the same. That classic dissection we just talked about, that's a class 1. But you could also have a class 2, where blood is just bleeding inside the wall, creating a bruise or a hematoma without a clear entry tear. Or you could even have a class 4, where a bit of plaque buildup, an ulcer, basically punches a hole through that inner lining. Each one of these is a different kind of failure, but they're all incredibly dangerous. Now that we know what's physically happening, we have to get to the most crucial step: classifying the damage. And this isn't just some academic exercise. This is the step that determines if a patient is rushed to the operating room right now or if they're managed with medication. So, out of a few different ways to classify these things, the one that really matters in the heat of the moment, the one that guides the life or death decisions, is called the Stanford classification. It's simple, it's fast, and it's all about action. And here it is. It all comes down to one simple question. Does the dissection involve the ascending aorta, that first piece of the pipe coming right off the heart? If the answer is yes, it's a Stanford type A. That is a surgical emergency, full stop. The risk of that tear spreading backwards and blowing out the heart is just way too high. If the answer is no, it's a type B. And for those, the initial plan is usually medical management. That single distinction is the most important factor in a patient's survival. Okay, so we've got the two types figured out. Now let's talk about the other major player in this drama: time. With a diagnosis this critical, the clock starts ticking the second that first wave of pain hits. This timeline here shows us the different phases. See that first window, less than 24 hours? That's called the hyperacute phase. That's the zone of maximum danger. It's when getting the diagnosis right is absolutely everything. But getting that diagnosis isn't always so simple. Take a look at this number. It is absolutely staggering. Up to 40% of aortic dissections are missed on the first pass. 40%. It's just a brutal reminder of how tricky this condition can be to nail down. And why? Why is it missed so often? Because it's a master of disguise. Think about it. Severe chest pain, sometimes radiating to the back. What does that sound like to you? It sounds exactly like a classic heart attack. And that overlap is what makes aortic dissection such a deadly imposter. So how do doctors cut through that confusion and get the right answer fast? They bring in the heavy artillery: imaging. For a patient who's stable enough, a CT scan is the absolute gold standard. It gives them a beautiful 3D map of the aorta. But if a patient is too unstable to even move to the scanner, they can use ultrasound, either on the chest or by putting a probe down the esophagus, to get a crystal clear, real-time look at the aorta and find that tear. Once the diagnosis is locked in and it's classified as type A or type B, the road ahead splits into two very different paths, and the path taken is decided almost entirely by that Stanford classification we just talked about. This slide lays it out perfectly. Type A means one thing: surgery. And not tomorrow, not in an hour, right now. The team has to get in there and replace that damaged section of aorta before it ruptures. For type B, however, the first play is medical. The goal is to get the patient's heart rate and blood pressure way down to take stress off that damaged aortic wall. But don't let the words medically managed fool you. A type B dissection is still a ticking time bomb. Medical management fails if any of these complications pop up. If the dissection starts blocking blood flow to major organs, if the aorta starts to bulge and expand rapidly, or if the pain and blood pressure just can't be controlled. Any one of those, and it's an immediate pivot from medical management to a surgical emergency. So let's bring this all home. A patient hits the emergency room doors, clutching their chest, describing that tearing pain. What are the absolute, non-negotiable first steps to save their life? It really boils down to these 4 critical actions. First, access. Get 2 big IV lines in. Second, control. Slam the brakes on the heart rate and blood pressure to take pressure off the aorta. Third, analgesia. That pain is off the charts, so control it with powerful IV medication. And fourth, monitor. Watch every single heartbeat and every change in blood pressure like a hawk. These 4 steps are the firewall, the actions that buy the precious time needed to get the diagnosis and get the patient to the right treatment. Aortic dissection is a true nightmare scenario where minutes absolutely matter, and telling it apart from its more common cousin, the heart attack, can be the difference between life and death. So considering it's this silent threat, so often mistaken for something else, what's the most important takeaway you'll remember from all this? What part of this incredible race against time is going to stick with you?